Hello everybody. Today I'd like to talk with you about implementation science by trying to go past your readings into something a bit more specific. I'm going to talk to you about one particular framework for designing and approaching implementation science, which we will refer to as the CFIR model, and I'll tell you more about that in a minute. So as I mentioned, I look to this as being an extension to your readings for Module 7. And as I discuss the CFIR model, that stands for the Consolidated Framework for Implementation Research, developed by a variety of colleagues, and I'll talk a bit more about the development, and I'll also make sure to attach a Word document with the citations that support the information in this slideshow. I am basing most of this talk today on an article by Batis and colleagues that goes into practical recommendations for training individuals in implementation science projects. I found that their discussion, both in the logic of how they talk about the model and then apply it to their own work, I found that to be very compelling, and so my lecture today is very much a retell of the Batis et al. Article with a little deeper research blended in. So the CFIR model, as I mentioned, developed by several colleagues. Fixon is one of the most famous, Glasgow would be another, and Dr. Glasgow is now working in the Implementation Science Center at the University of Colorado at Anschutz Medical Center. May actually be a speaker in next week's conference. So scientists working on intervention science have been trying to develop a way of thinking about their studies. They all agreed that implementation research should occur in these small incremental steps. And they felt like in order to really get interventions out there when they were needed, particularly in large-scale prevention trials, we needed to understand ways to get past all of the waiting with efficacy studies and effectiveness trials and to find some way to have a more flexible intervention development process. In the old way of doing things, you could develop an intervention, manualize it, and then you'd go through years and years of testing it in trials that were in controlled settings, and then you'd move into those less controlled settings, and you might discover after 25 years of research that you got something wrong about your model, about the way you're trying to deliver it, about the implementation of your ideas. Well, Glasgow, Fixon, Damschroeder, those scientists and others were suggesting that we would save ourselves some time and actually get better data sooner if we simultaneously evaluated the implementation of our interventions while also evaluating their impact. So the CFIR model was their attempt to come up with a shared approach with clearly defined terms that would be flexible enough to apply across contexts, whether you're going to do implementation of an intervention in the public health domain, for example, or in a school or in a medical system. So the developers of the CFIR model identified 5 domains. I'd like for you to think about these as kind of 5 categories of things to think about when planning an implementation science project. You're probably going to have different amounts of focus on subsets of these domains. You're not going to simultaneously assess all of these domains in a developing project. So think about these as domains that contribute to the way you would describe your implementation project. Now, each of these domains has been validated empirically over the past couple of decades, and they've developed a lot of measurable ways to look at these constructs, some of which I'll highlight today. But it's important to note that comprehensive studies of the CFIR model in action in all of its moving parts has not yet been entirely conducted. So let's take a look at the 5 domains of the CFIR model. First, there are the intervention characteristics. These refer to basically what's going on with the program that you were trying to implement. The source of it, where did you get it, how was it developed? You need to be able to describe those things in a narrative. What's the evidence for the strength of the intervention? What does it mean for it to be high quality? How do you even define that? You have to be able to conceptualize the relative advantage of your intervention over the ones that exist out there in the world. Sometimes we need to look at the adaptability of the intervention. Is it flexible enough that it could work for people from different subgroups who might need it delivered in different ways? There's a concept underneath this domain that researchers refer to as triability. And that basically means, is it simple enough to pick up and do? Is it accessible? There's also complexity. Some interventions require complexity, and if that's the case, then there are often ways to develop modules or segments of an intervention that can be studied separately, so that the complexity of the intervention doesn't overwhelm the participants, and also that the complexity of the intervention isn't too hard to study given the numbers of participants and the amount of variability you may have in its delivery. So it's very important to be able to think about the complexity of your intervention and describe the complexity in whatever study or design you're planning. It's also important to consider the design, quality, packaging, or cost of what it takes to kind of manualize or develop your intervention into a product. So many interventions require a facilitator's manual. They may also include a participant's manual, and it's possible that they include things like videotaped examples for trainings. Those sorts of resources are part of what you want to think about when you're designing an intervention. What are you going to need as far as the products to communicate what you're trying to do? The second domain to consider when you're developing intervention or implementation science studies is to consider what the CFIR developers call the outer setting. These are the contextual variables that are going to impact the people that you're trying to reach, the participants in your study. So if it was a healthcare study, you'd want to think about the patient's needs and resources. If you were doing this study in a school, you might want to consider, what is the peer pressure going on in the school? What's the climate, the stigma, the social aspect of the setting within which I want to intervene? It can also be relevant to consider the policies of the organization you're working with, or the laws or the guidelines or the norms governing the setting within which you are polling your participants. You also want to consider any incentives that are either operating kind of under the surface or operating very explicitly. A third important domain of the CFIR model for implementation science is to consider what they call the inner setting. These are the contextual variables that impact the people who are doing the intervening. So many times this is your clinicians in a medical context. Interventionists, for example, could also be teachers or trainers, people who are delivering the intervention. In the inner setting, what you have to think about is, what do those people who are going to deliver this intervention need to be successful? What kinds of resources do they need to have? What sort of resources do they already have, and where are the gaps? What's the culture like of the organization within which they work? Is it a culture that encourages innovation, or is it one that encourages rule following and more rigidity? It's important to understand if the overall climate of the organization is open to change, or what some scientists call implementation ready. And there are actually measures that you can use that assess the quality of openness to new interventions and ideas. And those sorts of implementation climate questionnaires can be really useful in school studies, for example. Adaptability of the organization is another important part of the inner setting. How easy is it to put changes into real action? And then lastly, another example would be, what kind of communication is going on amongst the individuals that you're trying to reach? Do your interventionists have easy ways to get with their participants? Is there easy, confidential, careful communication, or do you need to build those networks to be able to move forward? Example of what you might study in an implementation science project focused on the inner setting would be what Betis and al. In their article describe in their efforts to identify best practices in training personnel or in adopting a new intervention in an agency or organization. So they highlight several different measures of the interventionists that I think are very, very useful for implementation science studies in our field. The first is adherence. These are measures that look at the degree to which the interventionist actually delivered the intervention as intended. So adherence has to do with whether the interventionist delivered the intervention in a way that was true to the protocol. Now, in some other studies, you will see that interventionist variable be described as fidelity to the intervention and doing it to the intervention's guidance. Either one of those terms could be used. In these training studies, Bates uses the term adherence because the interventionists are trainers and they want to make sure that they're adhering to the protocol. In other clinical studies, we sometimes use the term adherence for what the participant or the patient is supposed to do. Did they complete the homework? Did they do the things we discussed in therapy? So you may see the term adherence or fidelity referring to interventionists, and you may also see the term adherence referring to what patients or participants actually do. Now, Kendall and Bates wrote a really important paper where they emphasized the importance of flexibility within fidelity. This paper was presented in 2007, right around the time when manualized interventions for mental health were gaining traction. And Kendall and Bates suggested that while it's important that interventionists are able to deliver an intervention as the developers intended, they suggested it's equally important that they be able to individualize the delivery to fit their style or to fit the specific needs of the patients in front of them. Kendall's point was that if you constrain talented clinicians, you'll end up really missing the point in your intervention. So to Kendall, you don't necessarily want 100% fidelity. You want flexibility for the clinician within a set of standards you're going to be faithful to. And to Kendall and Bates, these standards are that they can understand the critical elements of the intervention, the general principles, and that they could make good decisions when faced with a clinical dilemma that is, in a sense, off book. So there are ways to measure fidelity that account for flexibility. And if you'd like to learn more, check out the Kendall and Bates article. Another important measure that fits with the inner setting is the competence of the interventionist. This is the level of skill demonstrated. Now, many times we look at knowledge or beliefs of interventionists. That's actually handled as a within individual variable a bit later in our framework. Here, we're looking at the skills that are seen within the intervention context, and it's often evaluated at a team level and not just a clinician at a time. Transfer of training refers to finding evidence about the use of the skills that were learned in the intervention in the future in different contexts. And gathering data on how well skills have transferred or sustained over time is quite challenging and an important part of implementation science. And lastly, Bradley and colleagues identified an important aspect of measuring the inner setting that they called positive deviance. These, they described, are individuals who were the most successful at adopting an innovation into their practice, and perhaps they did so in a creative way, in a way that wasn't really expected or manualized. The point of Bradley and colleagues is that as you're trying to understand what's going on in the inner setting around this implementation effort, it can be quite important to look at your outliers, those people that really excelled, and try to find out, often through qualitative measures, how they actually accomplish that. So the fourth domain then of the CFIR model is to consider the individual characteristics of the interventionists. These are those within-person variables that are going to impact implementation. This is where we get into knowledge, beliefs, sense of self-efficacy, the individual's commitment to the organization, and their own personal openness to innovation. So less about the setting, less about the organization or the sort of zeitgeist of the place, more about individual values and characteristics. And for some interventions, you'll want to know about a very specific characteristic of the interventionist. Maybe it has to do with a certain communication style or a certain ability to empathize or to set limits. You could put some of those sorts of measures in your framework for thinking about implementation science in this aspect of the model. And then the fifth domain to think about in designing an implementation science project is to think about measuring the implementation process itself. This has to do with documenting how you're going to proceed to roll out the intervention. It's important to use mixed methods, qualitative and quantitative methods, for tracking what you did in the planning process, how you engaged your participants in the intervention, how you delivered it, what aspects of executing it worked, how long it took to work. You'll need to have some time to reflect on your pilot efforts as you go back and revise in a process we'll talk about in a moment called the iterative process. But you also need to, in your reflection, do some objective evaluation so that your revisions are really driven by data. So you can see that as you are working on an implementation science project, you are probably thinking about or dipping into parts of this framework each time you do a project, and you sort of will build your way through the whole framework. Now, one of the underlying assumptions of any implementation science project, but particularly within the CFIR model, is the importance of an iterative process. This is basically a process of development and revision, a process that is really active, dynamic, and influenced by data. The thought is that interventions, in order to work, particularly large-scale preventative interventions, need to be able to adapt to changes in the overall culture or in the context. Therefore, this older model, as I mentioned, of efficacy to effectiveness to then we're going to go back and see what we want to change, that's just not flexible or dynamic enough. So implementation scientists realized in the late 90s, early 2000s, that psychology and prevention science needed to learn from software product developers, that we really needed to think about new product models as an analogy for how to come up with really feasible, useful, sustainable, scalable interventions. Now, in a new product model, you basically create these feedback loops that go from the end user, so if you were studying a therapy, that would be the person receiving the therapy, to the developer, the person who created the therapy, and back again. You could also have feedback loops in that analogy from the therapist. Maybe you're studying how well you've trained the therapist to implement the intervention, while you're also trying to understand from the therapy participant how satisfied he is with the intervention. So you have these feedback loops from the end user to the developer and back. At every step in the iterative process, and I'll tell you about those steps in just a minute, you're going to enact these feedback loops as many times as you need to until it's good enough to go on to the next step. Each part of the iterative process usually requires an ongoing bidirectional back and forth in its development, requiring collaborations, relationships, trust, whether it's university community partnerships, healthcare, working with community practitioners, or even within an organization. Iterative processes require an openness to reinforcing effort, to recognizing that even the best efforts are going to fail at some degree, and that our hope is to learn from those failures, pick up, and keep going. So you acknowledge from the beginning that what you're doing is messy, it's going to take time, and you are going to learn from your mistakes. That's my kind of science. So, what are the steps of an iterative process? Well, these are briefly described in the Betis article, and they send you to the primary source. Crawford and De Benedito in 2010 do a beautiful job of describing each of these steps in much more detail. I strongly recommend that article. So what are those steps? Well, we begin with opportunity selection, where you have to figure out, in my particular field, what do people need? What's the next step? What are people in the market for? In other words, a place where there's a gap, where there hasn't been the kind of dissemination or sharing or development of an intervention that's really needed. So your first step is to identify your opportunity. Your next step is to generate the concepts, the key elements of your product. So you have a social problem you want to address, you develop an intervention that has theory-driven key elements that you want to implement. In the stage of concept evaluation, you're now trying to systematically test each of those critical elements that you hypothesized were important. You're going to, in a sense, deconstruct the intervention as you are developing it to make sure that all of those parts are needed and that all of those parts actually do stand alone. As you move into the development phase, this is where you're going to do your best with your team to create kind of a rough draft of your intervention. It's going to be like a first draft of your treatment manual, or it's like a rapidly made kind of brief, inexpensive version of what you want to do. And this rough draft is intended to be imperfect. It's made quickly, but it's enough that you can do the next phase, which is to launch it, presenting it to potential customers, and examine lots of different aspects. Ask them to give you feedback in many different ways on how usable your product is. So if it's a manual, can you read it? Can you tell what I'm asking you to do? Are you satisfied with the intervention? Does it seem to deliver high quality practices? Do you believe, end user, that this product could actually help you? And this is also the stage where you need to think not just about your intervention plans, but what are the plans for getting others to adopt the intervention? What are your plans for promoting what we call uptake, which is when somebody new tries it, and adoption, which is when an organization commits to doing it. So you often need to generate individual uptake before you get organizational adoption. And then the last step in this iterative process is iteration. And in a sense, it's a step that comes after every other step I just mentioned. Because as you go through each step, you're going to learn from your efforts, revise and do it again. And oftentimes we will set specific decision gates or objectives for what we have to meet before we can move on to the next step in the iterative process. So what kinds of designs work well if you're trying to study different parts of an iterative process? Well, I know it sounds complex and you're probably thinking that's going to take forever, and all of those things are true. But basically, you can be working in an iterative frame of mind as long as you are constantly paying attention to balancing the internal and external validity of your study. So it's really a balance. There are times where you have to compromise a bit on internal validity because you're in a real world environment and you just have to make a change that wasn't in the manual. So you have to, in implementation science, be mindful of choosing designs that give you flexibility to balance internal and external validity. So 3 different designs to consider. The first is practical clinical trials. Second, hybrid studies, such as the efficacy effectiveness model. And the third are formative evaluations, which could actually be thought of as an approach you can integrate into each design. So in the remainder of this talk, I'm going to just chat very briefly about each one of these 3, just enough so that you know more about it and can look it up if you'd like to learn more. Pragmatic clinical trials are, to me, a really fascinating way of doing science. In fact, you'll notice on the slide there's an NIH toolkit that can take you through running a pragmatic clinical trial. And this toolkit is wonderful. It was designed for physicians, community-based or university-based doctors who were clinicians first, researchers second. And so there are several different training modules to help those clinicians that are on the ground design and implement a practical clinical study of an intervention. So I find that the material is really reader-friendly and quite practical. So take a look at that if you're interested. In general, a pragmatic clinical trial is also called a practical trial. We're getting this definition from Wikipedia, and it's a clinical trial, so it's looking at the effect of an intervention, but it's focused more on associating specific aspects of a treatment with specific outcomes in a real-world environment, often a healthcare environment. So it's less interested in looking at links between treatments and the cause of disease, and it's much more about understanding what practices are associated with what outcomes in the real world. and the inclusion-exclusion criteria are usually much looser than they are in more controlled trials, and that's because the real world is messy. So you encounter a lot of variability right from the beginning. Now, Califf and Sugarman do a nice job of discussing the importance of pragmatic clinical trials, and they basically suggest that this is the best design for the primary purpose of informing policymakers, because you have to be able to show data that takes into account the potential benefit or impact, which would be what we used to call effectiveness data. We have to think, though, also about the costs, the burdens, and the risks, both for the individuals who participate and the people who are delivering the intervention. So pragmatic clinical trials are clinical trials that emphasize practical aspects. Messy science, often very, very large N science, and that's how we can handle some of the errors that you might get in having such broad inclusion and exclusion criteria. I shouldn't say errors, but your difficulty making strong interpretations of your data based on some violations of some assumptions. Second area, which I think is fascinating, could be a class all on its own, are hybrid designs. So these are ways to set up your experiments in the real world, so that you can simultaneously take a look at impact, what your intervention is actually doing to your outcomes of interest, while also looking at how you implemented the study. So it is a mixed methods approach often that combines looking at intervention impact and implementation process. Now, Cullen et al. Go into great detail in a fascinating way about 3 different hybrid types that they feel could be quite useful in prevention science and other aspects of clinical medicine. For our purposes, I just want you to have a working idea that these things exist, and if these designs intrigue you, I strongly recommend you check out Cullen's documents. So the first type is where you are testing the effects of a clinical intervention, you're looking at those relevant outcomes, and at the same time, you're simply gathering information on implementation. So you're gathering the attendance to your sessions, you're gathering data on the fidelity of the delivery of the intervention, you're looking at the satisfaction with the environment, that sort of thing. The second hybrid model is when you are dually testing specific strategies for clinical intervention and strategies for implementation. So this hybrid model is kind of taking a slice of the intervention and really looking at it much more deeply than simply trying to broaden your lens to include outcomes and implementation. Here you have very specific hypotheses about certain strategies that you want to examine. And then the third hybrid type tests a specific implementation strategy. That's where you're putting most of your effort, and in the meantime you're gathering some information on outcomes, but you're always kind of soft pedaling the outcome part because you are recognizing that not every participant is probably getting the same dosage or the same experience in the intervention because you're monkeying around with the implementation aspects. So in this sort of design, you are focused on implementation. You come up with some preliminary estimates of potential outcomes, but you're really not testing the outcomes themselves because you're not committing yourself to delivering the same intervention across all your participants. A lot of pilot studies fall into this third design. Now, formative evaluation is a fascinating way to learn about what's working and what isn't in an intervention study. We won't have time today to go into it in depth, so I will give you a definition, and then I'm going to be recording a separate episode, a separate lecture on an example of conducting a formative evaluation, which I hope you'll take the time to listen to. So, in learning about formative evals, let's start with a definition. Stetler and colleagues would describe it as a rigorous assessment process, which is designed to identify potential and actual influences on the progress and the effectiveness of intervention efforts. So it's really about being planful, about studying process as much as outcome. Schuster and colleagues describe it as an effective first step in guiding program improvement by identifying participant preferences and yielding information that's pertinent to making program decisions. They further state, this methodology thus enhances the likelihood that program refinements will be relevant and feasible. And they provide some links to some other authors who go into some, I think, very helpful examples. So in general, formative evaluations allow you to evaluate the interventions while you're designing them, while you're piloting them, even while you're conducting an efficacy, effectiveness, a PCT, or a hybrid trial. In a sense, formative evaluation is where you are kind of studying how you built the plane while you fly the plane. But it's a process that can be woven in at different steps within the implementation science process, and there's a great deal that we can learn from a mixed methods approach where you combine perhaps interviews, surveys, quantitative and qualitative ways of gathering information from stakeholders who have lots of different perspectives on your intervention product. And hopefully you'll come out with a stronger intervention that's really ready for deep study of efficacy, effectiveness, and sustainability. So in conclusion, thank you for your attention. I just want you to know there are several frameworks for implementation science. We've just covered one today in depth. There could be many more that catch your attention. CFIR is helpful, in my opinion, due to its clear definitions and its logical structure. To me, it's a good one to get started with. Then when I looked into other frameworks that might help me conceptualize different kinds of projects, I just found that this one gave me a foundation with which to pursue some other more complex frameworks. And as I mentioned in the next lecture, I'll present an example of a formative evaluation project from the real world. So thank you for your time and attention. Hope you guys are doing well.